All right, we are at the top of the hour, so let's go ahead and get started. Thank you so much, everyone, for being here today. We're so excited to have you here for our discussion today on reaching optimal patient outcomes through interprofessional and collaborative care. Before we get started, I did want to mention a couple of things. You will notice that your audio is muted. We've gone ahead and muted everyone's audio just to minimize disruptions and distractions throughout our presentation. But we do want to hear from you. So please go ahead and use the chat button. Let us know where you're joining us from and what you do. We love to hear from you. And if you do have questions during the presentation, we also have a Q&A option. So if you hover over your black Zoom bar with all of those options, you should see a button that says Q&A. Go ahead and submit your questions there. We will save them all at the end and take time to go through all of your questions at the end of the hour. So again, use the chat to kind of introduce yourself, let us know who you are and where you're joining us from, as we love to hear from you. And then for the questions, please submit them in the Q&A. And with that, I want to go ahead and introduce our special guest today, Dr. Diane Schadewald. Dr. Diane Schadewald is a clinical professor emerita from the University of Wisconsin-Milwaukee School of Nursing. Her work as the author and editor of the 5th edition of Zaccagnini and White's Core Competencies for Advanced Practice Nurses, published by Jones and Bartlett Learning, was recognized by the American Journal of Nursing as the first place book for 2024 in the category of advanced nursing practice. She's been certified as a women's health nurse practitioner and a family nurse practitioner since 1993. Her Bachelor of Science is from the University of North Carolina, Wilmington. Her Master's of Science in Nursing is from the University of North Carolina, Chapel Hill, and her Doctorate of Nursing Practice is from the University of Minnesota, Minneapolis. Dr. Schadewald is currently working part-time at the University of Minnesota School of Nursing on a research grant focused on help-seeking behaviors of Indigenous and Black women who have experienced intimate partner violence. Her past work includes topics related to health policy, nurse-physician communication, prenatal care, and women's health issues. And with that, I will turn it over to you to get us started, Dr. Schadewald.
Well, thank you for that introduction. And so if you want to advance the slide to, all right, so thank you again for that introduction. I would like to start with this quote from Dr. Amy Edmondson. She's the author of The Fearless Organization, Creating Psychological Safety in the Workplace for Learning, Innovation, and Growth. And her work on psychological safety has been used a lot in interprofessional education. So she maintains that great teams consist of individuals who have learned to trust each other. Over time, they have discovered each other's strengths and weaknesses, enabling them to play as a coordinated whole. Then the objectives for this presentation are as follows. You're going to hear about definition of concepts of interprofessionalism, collaboration, and collaborative care. There is going to be a little information on the historical and current professional cultural differences that may contribute to barriers to optimal patient outcomes. It's going to be recommendations to resolve interprofessional conflict, and then some information on developing interprofessional behaviors and policies to promote optimal patient outcomes. So when you're thinking about this presentation, some of the content covered is also relatable to the AACN's core educational nursing competencies for interprofessional partnerships, which are as follows: communicate in a manner that facilitates a partnership approach to quality care delivery, perform effectively in different team roles using principles and values of team dynamics, use knowledge of nursing and other professions to address healthcare needs, and work with other professions to maintain a climate of mutual learning, respect, and shared values. This is a definition that can be used for interprofessionalism, and it grew out of a 2021 structured literature review that was done by Flores Sandoval and colleagues, where they looked at concepts and uses of terminology, and they came up with this definition for interprofessionalism. That is an interaction of individuals who represent a particular discipline or branch of knowledge, bringing their unique educational backgrounds, experiences, values, roles, and identities to the process. Collaboration. This definition is from notes that I took in a 1992 symposium titled A View of Nurse-Physician Collaboration Through the Lens of the Ethic of Care. And I helped organize this symposium during my graduate work at the University of North Carolina, Chapel Hill. The keynote speaker was Adele Pike, whose work includes moral outrage and moral discourse in nurse-physician collaboration. So this quote may well be from her, but I didn't indicate in my notes that it was absolutely from her. But I like this definition of collaboration. Collaboration is a process of working one with another. It implies trust and respect, not only of each other, but also of the work and perspectives each contributes. The concept suggests a bond, a depth of caring for the other and the relationship. It incorporates notions of a synergistic alliance that maximizes the contributions of each participant. Now, when you're thinking about collaborative care, you can look to the Robert Woods Johnson's definition of collaborative care that was included in their 2015 publication, identifying and spreading practices to enable effective interprofessional collaboration. And this definition is for collaborative care is active participation of each discipline, where all disciplines work together. Disciplinary contributions are respected, the patient and caregiver are engaged in the process, and leadership on the team adapts based on the patient's needs. So the leadership can change. Now I'm going to touch on some historical and current factors impacting interprofessionalism. These key issues contributing to patient outcomes that were identified in the 2001 Institute of Medicine report are really still in effect. And they utilize these factors in their 2015 publication, identifying and spreading practices to enable effective interprofessional collaboration. They use these for measurement as to where we've gotten. But if you're thinking of the factors, these issues of complexity of knowledge, skills, interventions, and treatments that are required to deliver care, there still is an increase in chronic conditions. Healthcare systems are working on this, but they are often inefficient and disorganized in their delivery. And then there are challenges to greater implementation of information technology. As I said, technology is wonderful, and then again, it isn't. Looking at the past, historically, there was an article published in 1968 in the American Journal of Nursing called The Doctor-Nurse Game. And in this game, the nurse would need to use the suggestion without appearing insolent. And the reward for doing that from the physician was getting the gaining the doctor's esteem. And then if they're on the penalty side, if the doctor's has a phobic posture of omnipotence, then the reaction to that is that interferes with the nurse-physician relationship. Now, I'd like to ask you in the next slide, have you experienced the doctor-nurse game? So if you want to go ahead and indicate whether you have experienced this or not, we'll give you a minute or so to do that. So you can indicate your answers. Okay, so the results are, it is still happening. That only 15% of you said no, never. 8% yes, rarely. Occasionally 38%, and frequently 38%. So we're still there. Go on to the next slide, please. These are factors that I feel contribute to the historical culturalization or socialization of nurses and physicians. The nurses historically considered themselves or being considered as handmaidens, where the physicians were told that they needed to be omnipotent, they needed to be godlike. The nurses were doing patient observation and monitoring, where the physicians direct care. Of course, as nurses, you develop nursing diagnoses. The physicians are responsible for the medical diagnoses. The nurses are to follow the doctor's order, rarely questioning, whereas the physicians were to give orders, and if their orders were questioned, they were often defensive. The nurses were responsible for the patient's well-being, mostly, where the physicians were acculturated to feel like they were responsible for the patient's survival. Now, if we look at current culture of nurses and physicians, and in the category of physicians, I included advanced practice nurses, but I believe now in our educational programs, we're really acculturated to consider each other as colleagues and team members. Nurses still are the ones responsible for patient observation and monitoring, and the physicians and advanced practice nurses really for directing care. Nurses still for developing nursing diagnoses, physicians and advanced practice nurses for the medical diagnoses equally. Nurses now follow orders, but they have a high responsibility to question if orders are appropriate. And the physicians and advanced practice nurses give the orders, but they need to be open to accept review and or input about appropriateness of orders. So they have to be really open to accepting review or input. Equally, the team members are responsible for the patient's well-being and survival. These are my thoughts. Barriers to developing an interprofessional mindset that can be identified are that many schools and colleges are focused on only one health profession. There's a school of nursing and that's it, or there's a school of medicine or a college of medicine, and they're standalone buildings. So they're focused just on that one profession, or, social work, pharmacy, etc. Other colleges and universities have separate educational tracks, but they're still, there is a completely separated educational track for each health profession, never between two shall meet. Another factor is there is a lack of shared courses very often, and in schools or colleges, universities that decide that they want to have some common courses, such as in anatomy, physiology, pharmacology, etc. Students tend to self-sort by profession. While I'm in the School of Nursing and I'm hanging out with my nursing colleagues, and I'm in the School of Medicine and, or I'm with the rest of my medical students. So one way to overcome that is for the instructor to assign a group assignment and purposefully assign students from different professions to being in the same group. That would be one way to overcome that barrier. And even in the best circumstances where you're really trying to have at your university or college supporting interprofessional experiences, there's a real big complexity in harmonizing the schedules, because everyone, okay, we have this on Monday from 3 to 5, and we can't change that course, and you have this other course at that time. So there is complexity in harmonizing schedules that can make it difficult to have interprofessional experiences. So these are the barriers I feel exist. Okay, so what can we do about it? Methods to resolve interprofessional conflict. The real, with conflict, a key way to work and to resolve conflict is active listening and listening. If you're thinking in communication, listening is extremely important. And that's why I have this highlighted on this slide. And then if we move on, some measures to improve communication that have been identified is to maintain eye contact. If you have eye contact, it indicates that you're interested, that you're attentive to what's going on. You want to try to speak concisely and avoid jargon. Each profession has their own jargon. And so if you avoid that, you can improve your communication with others. You want to use questions wisely. You want to use questions to clarify information received or to elicit further information. You want to avoid qualifiers if you're asking a question, because they reduce the effectiveness of your message, or if you're making a statement. Don't say, well, sort of, or kind of, or I don't know if you'd be interested. That kind of denigrates your message. So if you avoid those qualifiers or tags, that's very helpful. You want to be aware of gestures that you're using, facial expressions, your posture, sending positive nonverbal signals is very important. And those can include conveying warmth with smiling. If you lean forward, it indicates that you're receptive to others' messages, and using open palm gestures also suggests accessibility. Avoid being defensive. Accept what feedback you're receiving without a defensive attitude. And then, which kind of feeds into avoiding responding emotionally. You don't want to ever raise your voice, yell, or cry. You can find more suggestions about measures and methods to improve communication in a number of sources. I really have liked Joseph Grenny and colleagues' work in their text, Crucial Conversations, and also Elizabeth Sullivan has done some good work for nursing about becoming influential. So I would recommend those two sources. Now, measures to improve conflict resolution. This does come from Grenny, and it talks about how you need to be aware that aggression is fueled by perception. So you have to check your perceptions. Intolerance, if you're intolerant of the others, that's going to fuel aggression. Misunderstandings, you didn't hear clearly what someone else was saying, and a sense of lack of control. So all of that it fuels aggression, and needs to be considered when you're trying to deal with conflict resolution. If you approach and consider using words such as we, us, or our, when you're talking about what's going to happen, that really indicates that care is collaborative and not dictated. And then another important aspect is to think about collaborative conflict management, which is where you use conflict in a constructive way, so that you end up using a conflict positively, and then you have a larger shared pool of meaning for the team members, and you end up with better decisions. And all of that comes from Grenny et al. Also. Now, I want to touch on some factors contributing to conflict in the workplace that have been identified by many researchers. And those include time pressures, increased workload, unrealistic expectations, and then other factors that also can contribute to conflict in the workplace are multitasking and mistaking the chart for the patient. So those don't have as big of an input as time pressures, increased workload, and unrealistic expectations. So now I want to ask you, did your educational program include tools for how to address these factors? And you can record your answers, please. Thank you. Okay, the results are most had 60% of the attendees have had education about how to address these factors. 30% frequently, 30% occasionally, but 40% have had it, but just not very often. It's been rarely covered. So I'm going to give you in the next slide some ways to work with conflict in the workplace. There are different mnemonics that have been come up with that help you remember how to work with conflict. And this could be in the workplace, with individual patients, or as nurses, we know that really anyone can be your patient. The organization could be your patient, right? So the Calmer approach comes from Palm, Shahady, and Palm. They published this recommended approach for management of difficult clinical encounters in family medicine in a publication in 2004. But if you look at family practice website, this approach, it remains recommended to this day. So you want to use the conflict as a catalyst for change. And when you're thinking about change, and you're wondering where the potential for this being a catalyst for change, you really need to identify where the individual or the organization is in the change model. If you're thinking of the Prochaska and DiClementi's theoretical model of change, where there's pre-contemplation, contemplation, preparation, action, and maintenance. So try to figure out where the individual or the organization is in that stage of change. And then alter thoughts to change feelings. So you want to discuss specific negative feelings and their impact. And in doing that, you have to internalize and think yourself, well, what are my negative feelings about this particular conflict? So that you want to identify those too, and alter your thoughts to change those feelings. And here we come with my listening thing, listen first and then diagnose. So you need to have good listening skills. If you're listening well, you need to make sure that you're eliminating barriers to communication and finding ways to improve the relationship. Make an agreement. You want to co-author a health improvement plan with the client or the patient. So you want to have it, an agreement as to what the plan is. Set reasonable goals for the next follow-up as part of the education. Providing education and then setting reasonable goals and having them input on how the goal, what goal should be established. And then reach out and discuss feelings. So that really is developing a self-care strategy. Another technique that is recommended for use in health communication to decrease conflict in the workplace grew out of the NYU Macy Initiative on Health Communication. And in this, they recommend that you work in partnership. So it's the pearls technique. So either you have a partnership to work together, you have an attitude of empathy, and you want to acknowledge frustrations. And with that acknowledgement, apologize if as needed. You want to verbalize regret. I'm sorry this is happening, or I'm sorry this was perceived in this way. And then include respect. You know, I appreciate your feelings. I appreciate your way of looking at this, or I appreciate your concerns. Include legitimization to normalize your feelings. So, you know, many people would feel this way, or many organizations feel this way. So you want to include a legitimization in your communication, and then offer support and commitment to helping in providing support for resolving the conflict or working with them to improve the situation. Now, there is another technique that I didn't include on a slide that I wanted to also share with you. It was a technique that was developed in the late 90s by Lieberman and Stewart, and that's the BATHE technique, B-A-T-H-E. This is another communication technique that can be very useful. And it consists of 4 questions about the patient's background, or the client's background, or the background of the conflict or the problem. And then the affect, you know, how is this feeling? Then troubles, what troubles you most about this conflict? And then how is the situation currently being handled? This part of the mnemonic of BATHE. And then following all of this with a empathetic response. So the procedure takes about 1 minute, but you have to practice it with all of these communication techniques and methods for resolving conflict. Practice is very helpful. Okay, so because we're talking about, if you could go back to that last slide, the previous slide, what we're talking about in this presentation is about teams, right? Interprofessional and collaborative care, and with interprofessional, there's definitely a team involved, right? So thinking about the stages of team development is very helpful to know about. And these stages of SMALT were identified in 1965 by the psychologist Bruce Tuckman. And he started with the first 4 stages, and then in 1977 they added the last stage of adjourning. So now there would be 5 stages in development of teams or small groups. In the forming stage, during this stage, you get to know the team members, you begin to develop trust in each other, you determine the mission. What are we going to do? What is this team going to do? And also, what are the roles and responsibilities of team members? Then every group tends to go through the storming phase. And this is where trust is really developed. And that's developed by facing conflict directly. And you learn to listen. Again, this importance of listening. You learn to listen to group members with tolerance and patience. Then the next stage for group development tends to be the norming phase. And in this phase, there's really a team identity. We're the cardiovascular team, or, we're the whatever your team is working on. And in this norming phase, though, you want to make sure that there's not groupthink where, okay, the cardiovascular team thinks this way and that's the way we all think. No, different members can have different perspectives, and that's reflected in that third bullet point about the norming stage. You want to promote comfort for free expression. And so that's really important for the team to be successful. Then after you get through those first 3 stages, then you get into the performing stage. And here in this performing stage, you have to be able to set aside individual and professional turf needs. And you want to develop flexibility for tasks and roles. So in the forming, you're determining roles and responsibilities, but that's the roles and responsibilities for the team. And what each individual within the team does may change over time. So you need that flexibility for tasks and roles. And they do want to have a commitment to what you established as your tasks and goals in the performing stage. Then after you have accomplished your task or resolved the conflict, then you have an adjourning phase where it's important that you evaluate your performance and progress. Did we get where we wanted to go? Did we really get there? And you want to make sure that you're measuring your outcomes, and then pat yourself on the back, or the team pats themselves on the back, congratulates each other, and celebrates their accomplishments. So that's the information about team dynamics that's important to be cognizant of. Now, how are we going to developing interprofessional behaviors and policies? A little bit more on that. And I want to go back to the first, thinking about what I said on that first slide, but Dr. Amy Edmondson, her definition of teams, or her what she felt made up great teams. If you think about how great teams consist of individuals who have learned to trust each other. Over time, they have discovered each other's strengths and weaknesses, enabling them to play as a coordinated whole. So, helping to develop interprofessional behaviors, you want to really be cognizant that collaboration in practice improves when learners have the opportunity to work together in the clinical setting. And the learning together in the clinical setting, or a simulated experience, will be supportive of collaboration. So there's a feedback loop there. There is a recommended model for interprofessional learners, and that's the Interprofessional Learner Continuum model. And it illustrates how the learning continuum grows from foundational education to continuing professional development post-graduation. This model also highlights the enabling and interfering factors and the connection between health system outcomes and learning outcomes. So on the next slide, I have an illustration of the model. And in this model, you see how the interprofessional education really does need to start in your foundational education as and should be grow larger during graduate education, and really to continue with that development and to continue learning how to be interprofessional. Experiences need to be included in continuing professional development, and it's best to have that experience be even more prevalent. Now, what's going to help this happen, or maybe prevent this from happening, are the professional culture that you have, the institutional culture. A workplace policy or workforce policy can interfere or enable it, and financial is always a factor, right? What should grow out of this learning continuum where you keep learning how to be interprofessional should be the outcomes should be the reaction, improved attitudes and perceptions, improved knowledge and skills, collaborative behaviors, and better performance in practice. And all of that, whether that happens or not, will impact outcomes of individual health, population and public health, organizational change, system efficiencies, and cost effectiveness of care also. It impacts that. All of this came out of the Institute of Medicine's work in 2015. Now, I wanted to provide some resources that you could go to for continuing education. The healthcare escape room guidebooks are available through this link to the University of Minnesota site. The idea of using the concept of escape room, where you have to establish certain tasks before you can get out of the room, and each team member has a different task, or tasks that they have to accomplish collaboratively in order to get out of the room. I understand that escape rooms, the whole concept about escape rooms, grew out of some gaming theories and that. So I wanted to provide that link for you. And then a link to the Interprofessional Education Collaborative. They also have on this website, there are resources available that you might want to look at and use. And then, of course, the National Center for Interprofessional Practice and Education, which is now called Nexus. And it was first established at the University of Minnesota and continues to be housed there. But they do have at least an annual conference that you might want to attend if you're interested in becoming more aware of practices for interprofessional practice and education. I also, in this presentation, wanted to provide you with some information about developing policies to support interprofessional behaviors and improve patient outcomes. So when you're thinking about policy and how you can develop a policy, you have to work with current policy. You have to realize that policy is embedded within the missions, and values of organizations, and it's impacted or reflected by the resulting culture. So understanding these missions and values are really integral to development of trust in the performance of interprofessional teams. If the missions and values are not supportive, if you go back to that model, if the missions and values of the organization aren't supportive of interprofessional teams and development of them, then it's going to impact whether that can be successful or not. And then another recognition to Amy Edmondson's work is that it's important to ensure a psychologically safe environment for interprofessional practice where system changes can be properly addressed. So that's another important aspect that needs to be in place. And to have that psychologically safe environment, the Joint Commission has recommended a non-punitive incident reporting system where errors can be reported, and there still includes accountability for error. But if it's a non-punitive incident reporting system in the organization, that helps ensure that issues are brought to the forefront and aren't buried, so that improvements can be made. And then as doctors of nursing practice or researchers, you really know that you need to, if you're going to change a policy, it might be helpful to do a root cause analysis, of course, to find out, okay, use root cause analysis to inform policy if you're trying to develop a policy to ameliorate a conflict or a bad outcome. I like this cartoon a lot because there are risks with policy changes too. There can be unintended consequences. So there's the policy developer saying, I need a rock this size, you know, and oh my goodness, if you remove that, what can happen? So it's important to be aware that there can be unintended consequences and to try to make sure that you buffer for those, or that you deal with identifying all the potential consequences and how you will avoid unintended consequences when you're making policy change. And in doing that, that's where you have to really assess all the risks. So, and you have to make sure that the policy you want to implement, it's realistic, because if it's not realistic, it's not going to be implemented. And these are different stakeholders and factors that you need to take into account when you're developing policy. All of these factors influence policy. And then finally, in developing policies to improve or maintain quality outcomes, I do like use of Bartik and Potashnik's eightfold path in policy development and analysis. And I've shared their eight steps on this slide. And but you could choose a different process if you wanted to. Choose a process, but you should be purposeful. So you want to choose a process to analyze current policy. You want to be aware of facilitators and barriers to change. We could think back to Lewin's change theory, right? That there are facilitators and barriers to change. And you want to determine how to measure the impact of the new policy. Because if you don't know, if you don't have a way to measure the impact of the new policy, you aren't going to know whether it's successful or not. So you really have to come up with a way to measure the new policy to know whether it's working or not. And then to make sure that the policy is being implemented the way you wanted it to be, you have to develop an implementation plan for the new policy. And then, of course, how you're going to evaluate the outcomes. How are we going to know whether this really worked to help solve that conflict or the problem that we were wanted to address? So, and all of these processes are included in your DNP projects when you're creating a DNP project too. So if the Doctor of Nursing Practice Education makes you well prepared to follow these recommendations. So now I'm wondering if you have questions.
We do have a couple questions in the Q&A. The first question is from Lori. She asked, with the role of the patient changing, e.g. shared decision-making, how is this impacting interprofessional collaboration and clinical decision-making?
Okay. I think that it really is staying, it's an improving it. I would say it's definitely improving it. If you go back and you think about the methods I talked to, the Pearls technique or the Calmer technique, all of this really involve the patient in the shared decision making. So if you're going to try to address a patient's problem and have a good interprofessional approach to it, you're including the patient as a member of the team, I would advise. That's a good question.
The next question, will you send us a recording of the webinar and the references mentioned? Yes, we will be sending a copy of the recording. Do we know if that is going to include the references? I guess I don't know the answer to that part.
Yes, I am. There's a handout that I have provided, and the references, if you go forward in the slide deck here, you'll find that I have included the references. I think I've included all of them. If you move.
Yes, they are in the slide deck. Okay, perfect. Thank you. And then the next question is, how long do you think is a realistic time frame for implementation to be able to see quantitative changes with changes in interdisciplinary collaboration?
Oh, that's going to really depend a lot on the culture of the organization, I would say, and on the problem that is trying to be addressed. There is, with the increased focus on being interprofessional, although unfortunately we did see that the doctor-nurse game is still active, you know, through this presentation. It's a continuing work. And I don't think that you could put an end date to it, you know. I think it's going to be continuous. So I think it's hard to try to put a particular end date as to when we hope this will be accomplished, but it's kind of just keep on keeping on. And using the methods, you know, using the communicate as we become more adept at using the conflict management skills, et cetera, and become more focused, and more organizations become focused on a commitment to interprofessional practice. I think that will help move things along, but there will always be something more to do, I think.
That was it for the questions we have in the Q&A right now. I'll give everyone a couple more minutes to get any other questions in if there are any. But before we conclude, I did want to mention that there is a contact hour available for this webinar if you should so choose. There is a link in the chat to an email. So if you are interested in purchasing continuing education for this webinar, please go ahead and email us at info@dnpinc.org. Again, it's in the chat. And one more thing, as you are leaving the webinar, again, assuming that we don't have any more questions, you will see a survey pop up with just a couple questions about today's webinar. We'd really appreciate it. If you fill it out, it should take you less than a minute, and we do read all of your feedback, so we really appreciate any comments you might have. There's one more question, actually, that just came in. Is there a way to contact you if we have more questions?
Yeah, you could contact me through the University of Minnesota, schad013@umn.edu. I can put it in the chat. Or through Jones and Bartlett.
All right, there's the email address in the chat. Thank you so much. And I think that's it for our questions. So thank you so much, Dr. Schadewald, for presenting today, and thank you so much for everyone for attending. Again, you will receive a follow-up email from us with more information. Thank you so much, everyone. Have a great rest of your day.